And I'll give you an example. If you look across the United States, less than 20% of people live in rural America. But in the Avera footprint, it's almost 80% of people live in what would be defined as a rural footprint. So it is who we are, it's what we do, it's how we think, it's integral to the Avera mission.
Welcome to A&M Healthcare Industry Group's What's Your Moonshot podcast series, where world-class healthcare leaders seek to solve big problems. Listen as we talk to today's health system CEOs about the journey to achieve their moonshots.
Welcome to A&M's What's Your Moonshot podcast series. I am Aaron Banowski, a managing director in the Healthcare Industry Group. I'm joined by my co-host, Dr. David Shulkin, 9th Secretary of the U.S. Department of the Veterans Affairs and an A&M Senior Advisor. Today, we are thrilled to be joined by Dr. Ronald Place on the podcast. Dr. Place was named Regional President and CEO of Avera McKennan Hospital and University Health Center in May of 2023. He serves as the organization's leader for all aspects of healthcare delivery within the region, including its 545-bed tertiary hospital in Sioux Falls, as well as on-campus sites, the Avera Behavioral Health Hospital, Avera Human Performance Center, Avera Prince of Peace Retirement Community Research Institute, and more. In addition, Dr. Place is an extremely accomplished three-star Army general who led a $53 billion operation for the Department of Defense, playing a key role in merging three health services organizations under one umbrella. In his medical training, Dr. Place completed a general surgery residency at Madigan Army Medical Center, as well as a colon and rectal surgery fellowship at the University of Texas Southwestern. He previously served as a chief surgeon, deputy, and commander at multiple Army medical centers. Welcome, and I'm looking forward to a great discussion.
Well, good morning to you. It's wonderful to be joining you today. Thanks for the invitation.
And I too just want to add my thanks and of course my gratitude for all of your service to the country. I know you come from a family where your brother serves, and it's a big deal that people like you step up and help defend this country. So thanks for being with us today.
Again, my pleasure. And as I've mentioned to you before, Dr. Shulkin, I found it a privilege to be able to serve. So I'm just grateful I had the opportunity.
Wonderful. We're excited to speak with you today. So, first question is, we know you're committed and focused to ensuring the same level of quality of care is delivered to your rural community, which is a driving force behind your moonshot. Could you share more about your moonshot with us?
Sure. It's interesting. I had dinner the other night with a couple of my high school classmates, and all the stories being told is, often the case when old friends get together. And it just reminds me over and over again how people talk about 7 degrees of separation or 6 degrees of separation. Well, in rural America, it's often 1 degree of separation. And what I mean by that is we're small enough. The population of eastern South Dakota, southwest Minnesota, northwest Iowa, where Avera really is, it's small enough that so many of the people, or a percentage of the people, or somebody who knows that person. So it becomes very personal. And I don't mean that healthcare isn't personal in other areas, but because of that intense knowledge of the success and the challenges of the communities that we serve, it becomes more personal. And because it becomes more personal, then I think there's just that little bit more that gets done to support it. And I'll give you an example. If you look across the United States, less than 20% of people live in rural America. But in the Avera footprint, it's almost 80% of people live in what would be defined as a rural footprint. So it is who we are, it's what we do, it's how we think, it's integral to the Avera mission.
I definitely want to get back to this belief about how best to serve in the rural communities, because I think that's so important. And I think you've now had a chance to think a lot about that. But I know you're also from the community. So therefore, this is part of your DNA. But I just wanted to take a back step for 1 second in asking you to share with our listeners about your own experience. I know for me, I had spent my time running hospitals, mostly in the Northeast, not in rural areas. And then I had the privilege of entering government in the, first in the Obama administration to run the VA healthcare system. And for me, I know it was a big change from a private hospital into a public system of care. You actually had the opposite experience. You spent almost all of your career in the military, and now you're running a large not-for-profit system in South Dakota. What was that like for you to step out of running the Defense Health Agency and all of your experience in government to take over a private hospital like Avera?
I mean, healthcare is healthcare. So the center of gravity, what we do doesn't change. The location has some uniqueness to it, that's for sure. But the huge majority of it is, do you have the right people? Do you give them the right resources to be successful? Do you have feedback mechanisms to help, inform your blind spots? Do you recognize who are the formal leaders, who are the informal leaders? How do you get them together? What's the risk mitigation, whether risk evaluation? That's all, doesn't matter where you are. That's all the same. That's just leadership in a healthcare environment. But there are things that are different. A couple of good examples. As you mentioned in the introduction, I'm responsible for the Prince of Peace long-term care center. That the Department of Defense doesn't do that, right? Dr. Shulkin, we partner with the VA. So if there's a service member or a family member for whom we can't provide a return to a normal-ish quality of life, then we partner with the VA for those sorts of issues. So learning about long-term care, staffing ratios, risks, compensation, financial aspects, that was a steep learning curve for me. And I think that I'm no longer on the steep part, but I'm still learning a whole lot about long-term care. So that's one part of it. The second is financing. As you very well know, the way that we do financing in the federal government is we go to the legislatures and we talk about, this is what we're doing, these are the risks that we see, these are the important programs, let's put it in the budget. Then it goes to the appropriators and they say yes or no, and there's hearings about it, and we work it all out, as opposed to, you're going to do the work, we're going to pay you for the work, and some things get paid well, some things that don't. There are certain federal programs that will compensate for this, that, or the other thing. So learning the different financing has been another interesting thing to learn about, but it all makes sense, right? You just got to understand the rules. So I guess what I'll say is that no matter where you go, from federal to non-federal, for-profit to non-profit, et cetera, in general, the center of gravity is all the same. And you just have to understand what the rules are and how can you use those rules legally, ethically, morally within the mission of your organization to then lead to at least short-term sustainability, hopefully long-term sustainability of the organization.
Yeah, no, I think that makes sense. I just wanted to ask you about one piece of it, and that is, getting things done in an organization. When you're in the Defense Health Agency, your general place, and people literally salute you and, say, yes, sir, I'm going to get this done. How about CEO place at Avera? I mean, is it harder to get things done, easier to get things done?
I think it's actually about the same.
Okay.
And to your point, I mean, I think there's a lot of people who think that military leaders get everything done by giving orders. And certainly that happens in some circumstances, and it has to in some circumstances, but it's uncommon. Best advice I ever got, and I won't tell you from what senior general that I got it from, perhaps offline sometime I'll tell you because you know him. But as I was frustrated about a particular thing. I was a colonel at the time. He was a 3-star at the time. And I was, maybe should I just give an order about this? What would it look like? And he said to me, Ron, if you have to use the power of your position to get something done, maybe you should rethink the strength of your argument. So I got all kinds of great advice over my career, but that one has stuck with me for a very good reason. If something doesn't make sense, if you really have to order people to do something and it's not an emergency, right? So look, we just got to do this. Then probably it's not worth doing. And then how can we get somebody else's idea that's going to be better than mine? Or how can we bring a group of people together to come up with a better solution set than we already do? So I'll just say this. In my experience in military healthcare compared to, at least as a leader perspective, compared to leaders in the not federal sector, leadership's leadership. It's not about giving orders. It's about understanding the organization, understanding the mission, bringing the right people together, finding the solution sets, and collectively going forward.
Okay, great. Thanks. Aaron, why don't we go back to you and, dig in a little bit deeper into the issue about how do you deliver care in the rural setting.
Yeah, no, thank you for that, Dr. Place. I think it's fascinating to think about the commonalities of what you experienced there in leadership in other places. Yet you are in a rural area, an area that covers, a broad geography with limited people. How are you using technology, leveraging technology, maybe AI or remote monitoring or telehealth in what you're doing?
Sure. I mean, the list is long. From remote monitoring, one of the first programs that we used now were people at high fall risk that historically we would put sitters in rooms. And one of the challenges with that is, first, it's expensive, but more so than that, it's kind of boring. If your only job is to watch someone and make sure they're not moving wrong, it's pretty easy to get distracted while you're doing that. So by using AI and remote monitoring, we can have a single person monitoring multiple beds. And because of that, they're like an airline pilot where they're scanning all kinds of different things. So it's no longer boring. There's enough feedback that's coming through so the monitor, the person who's doing the monitoring redirects people. And if he or she is unsuccessful in redirecting, that's when you now coordinate with the nursing staff on the local unit. So we're able to have lower falls, and that's true. We have lower fall risks from remote monitoring than we do with sitters in the room. And it's more rewarding for the staff. We're using remote nursing. We're doing it for both second nurse for things like pain medication validation and narcotics, or blood products where it requires a second nurse, where normally you would have to take a nurse away from her duties to other patients, but with remote, they're ready to help with that. They're useful for discharge instructions, as an example. So we can help people leave the dangerous environment that is an inpatient facility, but not feel rushed in it, in that this nurse is helping. Or we can use it for remote OB, again, rural sites. We have lots of critical access hospitals in our network who don't do nearly as many deliveries as their flagship hospital. So can we have good dialogue and from the experienced nursing staff here at our flagship facility to those that are doing not just OB, but med surg and peds and all the other things that they're doing. So lots of different ways of using remote nursing. We're using ambient listening for our outpatient physicians. It's outstanding in the initial symptom discovery and HPI, that sort of thing. For those who aren't comfortable in the physical exam dictating out loud, we're working through some of those things. It does a pretty good initial assessment and plan, requires a little bit of a physician oversight to make sure we got the right assessment and plan. But from a quality of life from the provider staff, it's taking, dozens of minutes to hours per day off their time just by using the ambient listening. We're in hospital at home. Now, be careful about how far out in the rural community you go with hospital at home, but we're doing that. We're doing telehealth. Most common, I guess, telehealth that we're using is infectious disease and pediatric subspecialties, just because there's so few of them, but the demand across the entire rural footprint is high. And for some of it, at least, it doesn't really require an intense physical exam by that specialist. It can be done by somebody else on the site. And then the technical knowledge and the cognitive information about those particular specialties within the flagship facility, but allowing people to live in their hometown and still get that subspecialty care to them. The list goes on and on and on, but that's just a smidgen of all the things that we're using advanced technology for.
I wanted to ask a little bit more about this because I love that vision and I love your ability to articulate those specific examples. So when you think about national health policy, reimbursement for rural hospitals. And, one of the things I think that you get a lot of agreement on in Washington is the support for rural healthcare. Do critical access hospitals have access to these types of technologies, or do you need to be part of a system like Avera to be able to afford the ability to even demonstrate the value of these technologies? Should health policy be supporting technology in rural healthcare more than it is?
Yeah, Dr. Shulkin, thanks for the question. As you know, it's a somewhat loaded question with lots of different areas that can go. I don't have any experience in an independent critical access hospital, and I can't say that I've spent any time digging into the details of what they have access to and what they don't have access to. So I'm reluctant to comment on that. I will say that the South Dakota delegation has been very responsive to the needs of rural communities and rural healthcare, and they are very supportive of thoughtful application of federal resources to maintain access to emergency functions. I think a good example of that is the recent change for rural emergency health. But rural emergency health is one step even smaller than critical access hospitals. But no kidding, you maintain an emergency department so that critical resuscitation can happen, even if you don't really ever have a census even of one in your hospital. So for those communities who are so small but so isolated that they need access to emergency service, that's one capability. Then there's critical access hospitals where there's particular funding available to keep them open for all of this very, very specific requirements. So the emergency department, a lab, basic imaging, basic inpatient capability, but not overspending on it. So I do think that there's good policy in place now that for those who are mindful of how they use those resources, we can continue to exist and be above the line, right? To be in the black, maybe not very far in the black, but in the black, and maintain those capabilities in our communities. I will say this, though, from my experience of being part of a system in this not-for-profit with 37 critical access hospitals, being part of a system makes it easier.
Yeah.
And the reason I say that is there's somebody who can maintain your electronic medical record, because it's hard to do by yourself. It's someone who can do the recruiting and the hiring for you, because as a small place in a small community, it's hard to do that by yourself. To maintain your financing, can you hire a CFO? Yeah, you probably can. But gosh, if you got a system that can do the intricate details and manage your tax return and all those other things that come with it, a centralized organization can provide significant support to a critical access hospital, such that all that they really need to focus on is the actual delivery in their community and be responsive and integrated with that central office who's doing a lot of that, that back office function, administrative function for them. So for us, at least, I can speak to how it's mutually sustainable. The back office helps us to be successful in the local communities. And by delivering really good quality care in the local communities, we make it much easier on the administrative back office to do their work as well. So I think an integrated delivery network is a very good way of doing it. And I can't really comment on the independence.
Yeah.
Well, one question is, as you were mentioning, the quality of care, et cetera, and you have to, it's especially in a rural area, be cognizant of access to care in terms of, emergencies and things like that. How do you deal with this? How do you improve patients' lives if you're dealing with, such a kind of spread out rural area in providing that care to people?
Yeah, well, I think one of the important ways is to maintain the same sorts of certifications and surveys and accreditations and all that everybody else does. And we feel very strongly on that. And the reason I say that isn't that we got this thing to hang on the wall. So prove to our patients that we're great. That's not the point I'm trying to make. The point I'm trying to make is it's good to have an outside set of eyes come in and look at your organization and either affirm, yes, you're doing all these things well, but also this is a blind spot for you, or this is an oversight for you. And as long as that's happening on a routine basis, in general, in safety culture, we get ahead of all those things. We fix things before they become problems. Now, that's not to say that, problems can't come up and we have to dig into the details and, how are we going to risk mitigate it so it doesn't happen again? How are we going to get some sort of solution to fix the problem for this particular encounter, et cetera, et cetera. But as long as you're ahead of the game and all of these programs and all these organizations are coming in to really look at your programs, that happens, the sort of challenging things are very rare. So first, I think it's important that you maintain those accreditations. And again, that's the reason for it, so that you stay ahead of it. But secondarily, that you invite others, even absent from an accreditation program, to just come in and look at your organization. Friends who are in other healthcare organizations or whatever, say, what do you think? Are we moving in the right direction? I think it's good for us to read. There's lots of different healthcare manuals that you can read. There's lots of people who are publishing on it. There's lots of journals. There's lots of things that as long as we maintain our awareness of what's happening in the industry, even if we're not waiting for an accrediting organization to come look at us, we can make continuous evolutions of the way that we think about care, the way that we organize care, the way that we integrate care. So I think all of those things together is how you maintain, even in a rural area. And by the way, I don't think it's any harder in a rural area than in an urban area to stay up on what's current. As long as you do that, as long as you're not complacent, the quality of care is going to follow behind.
Dr. Place, how do you feel about the workplace shortage issues and your confidence of being able to continue to deliver that high level of care? Do you see the workforce issues staying about the same, getting better, potentially getting worse? What's your sense in rural America about finding the right type of people to staff your facilities?
Well, I think that there's a cohort of people who want to work in urban centers, and there's a cohort of people who are open to the idea of rural. For those who are open, I don't think some of them know what rural is, and it's our job to be able to explain it and to talk about the goodness that's available in rural, and perhaps even some of the challenges, but not lie or not mislead, not try to sell
Mhm.
somebody on something, because if you do that, then their experiences aren't what they thought it was going to be. And not only do they leave, but they leave with a bad taste in their mouth. And now they're telling other people, hey, if you're thinking about rural, this is awful. And here's why it's awful. As opposed to, if this is the lifestyle you're looking for, if this is the patient population that you like to serve, if this is the way that you like to work with your colleagues, then this is the culture that may be useful to you. But I'm going to go behind that just a little bit, Dr. Shulkin. I think it's up to all of us in the way that we talk about healthcare and the way that we present healthcare, that we do our part to eliminate the challenging aspects of it so that we encourage people to join healthcare from an educational perspective. For people who may be on the fence, that no, really, being a physician is a good thing. Being a nurse is a good thing. Being a pharmacist is a good thing. Being a therapist, I mean, you go down the whole list. But if we're not, as a sort of global culture, if we're not showing how fulfilling it can be, if we're not showing how the hours can be challenging, but how it's useful and how it feels to give back and how it feels to be part of an organization that matters to the community, and how being associated with this gives you credibility for things that you want in your life. I think that's all of our responsibility to be able to do that. And then within our own organization, based on our own mission and our own culture and our own values, how it can speak to people who say, gosh, I want to be part of that. And then find programs, partnership programs, sponsorship programs that for those who otherwise wouldn't be able to go down this education pathway, we can help them achieve what maybe seems like a dream that they can't get, but now with an organization like Avera or others can find a way to get down this pathway to be able to give back in a meaningful way. So I don't think it's all doom and gloom as long as we take responsibility for where we can positively affect the out years. I think we're going to be okay. But then again, as you know, kind of an optimist.
Right. No, I was thinking as you were speaking, I was thinking I could almost hear you giving the same talk when you were in the military, because I know military recruitment is now challenging, right? We're falling
Yeah.
short on many of our recruitment goals. And I recently joined the faculty of USIS, which maybe some of our listeners don't know, is really America's medical school for the military. Do you feel that we need a medical school or healthcare education, because it's way beyond physicians, for rural America? Or do you feel like there's enough training happening in rural America already?
Well, yeah, I haven't looked at the national numbers in particular as it relates to rural. I can speak to South Dakota and the great relationship we have the University of South Dakota School of Medicine, and I know you have much knowledge about that particular medical school as well.
Mhm.
I think it does a fantastic job. I don't know the exact statistic who could go to the dean, but I believe it's 70%, give or take, of their graduates who end up practicing in rural America. So I
Mhm.
think if you give them an educational experience that matters to them, and you show them based on their clinical rotations in particular, this is what rural medicine can feel like. There is a very large cohort who are attending medical schools in relatively rural areas who want to continue to do that. And,
Mhm.
do we have our challenges in rural South Dakota for attracting this particular specialty or that particular subspecialty? The answer is going to be yes, but I don't think it's any greater than any other
Yeah.
urban, suburban, rural part of America. I think that if you're upfront, honest, good culture, good values, it all makes sense. You can bring the right people into your organization. And I think that at least in our aspects here in South Dakota, the South Dakota School of Medicine does a great job of preparing people
Mhm.
for rural careers.
Really hearing about what you've done in these rural communities is certainly inspiring. And it's really interesting. It's our listeners, perhaps that are in other healthcare arenas are listening. What other lessons learned would you share with them that these healthcare leaders from across the country would want to hear about what's working in rural healthcare and what they can apply in their areas?
Yeah, well, I'm not going to be so arrogant to suggest that I have it figured out. But thoughts that I think people should consider is the thing that matters the most is the mission. And Dr. Shulkin, as you and I have talked over the years, the mission of the military health to me mattered. And I think to the people who are serving in the military, it matters. This is young men and women who have volunteered to do whatever it takes to protect the American way of life, up to and including the loss of their life. And if that doesn't strike in your heart, the desire to help young people like that, then I don't know what could. So in the military, the mission was so important. And as I retired from the military, based on you have to go, Ron, you've stayed all that you can, you have to leave now. I didn't feel like I was ready to be retired. And so then I was looking for another organization for which the mission was really central to who they are. And while there's lots of great organizations around the United States, the one that really stood out to me happened to be where I grew up, back here in eastern South Dakota. So the mission of Avera is central to the huge majority of the staff. And I'm not going to pretend that there's not some, the occasional person for whom it's okay, it's a place to work. Mm-hmm. But that's not the case for the enormous majority of the staff here. And because of that, that's what cultivates the culture. That's what keeps it alive and growing. And as you're being recruited, you see it and you feel it. And if that feels good to you, then you're more likely to stay. And if it doesn't, then it's okay. Find a different organization for whom the culture does speak to you. But by far and away, mission matters. And then the second thing that I think that I'll add to that is we talked a fair bit at the beginning about, I think, standardization. At least that's the word that comes to mind for me. As most healthcare organizations, the central part of what you do is kind of similar, and standardization helps drive up quality, right? Variance is often bad unless it's accepted variance, and here's the reason why it's acceptable variance. But standardization is important as long as it's balanced against the very few things that make this organization unique. And it's balancing the growth of standardization against the uniqueness and characteristics of a particular organization. And you have to feed and water both of those things. Third is leveraging the great ideas of the staff. I mean, I have an occasional good idea, but I certainly don't have the patent on all the great ideas, not in military medicine, not in Avera, not anywhere. So how do you nurture the concept of ideas? Not just, hey, that's a great idea, let's do it. But people are scared to give their ideas, then it doesn't really matter much. So how do you cultivate the culture that says we're interested in the best ideas? And while we may be a resource-constrained organization, like all healthcare organizations are, at least the majority are, then how do you find the right resources and cultivate those really fantastic ideas that are coming out of the staff? But ultimately, and I've said it a couple of times before, ultimately you have to put all that into this different soup, because what you're really looking for is long-term sustainability. Why? Because it's the mission. And our whole goal here is to continue to do what we do. And as healthcare evolves, and we talked about some of those evolutions, as it evolves, how do you maintain your relevance over the long-term sustainability of the mission you're trying to provide for the communities that you serve? I guess that's sort of global advice that I would give.
Makes a lot of sense to me. And, I certainly connect with mission and connect with the importance of the culture, and it all starts with leadership. So I think Avera is very fortunate to have you at the helm there. And we thank you for spending the time with us today on What's Your Moonshot, and think that what you're working on and the importance of healthcare to rural America is so important. So thank you for joining us today. We're very appreciative of your time.
It's truly my pleasure. Thank you.
Thank you, Dr. Place. We appreciate you being here.
Alvarez and Marcel. Leadership, action, results.
Dr. Shulkin, that was a great conversation with Dr. Place. Rural health is just really, really important to the healthcare in this country. I was impressed by Dr. Place's comments around the leadership it takes to do that, which of course he gained in spades in the military, but also focusing on mission. The mission of the organization is what really drives him. That was really impressive to me.
Yeah, I've known General Place for many years, and I got to watch him operate in the military environment. And he really expressed it well when he said, "There's not much difference. Leadership is leadership, and you can see what drives him, and that's infectious. People want to work for somebody that believes in what they're doing, believes it's important, and where their values are as transparent as his are. You know, the issue about rural healthcare, quite frankly, is that it's not easy for many places to be able to continue to offer the types of services that they currently do. And so, I think that, as Dr. Place said, being part of a system sort of makes it easier. But for those that are in the smaller communities and still with independent hospitals and clinics, the question is, how can we help them? Are there different policies and different reimbursement mechanisms to help them stay in existence?
No, it's true. I recently met with a group of independent hospitals that are part of an association in the West, and it's interesting for them to come together and try to find ways to help one another, support one another, because they're so disparate in terms of what they're trying to deal with. But I think you're right. Ways that we can support the rural hospitals through policy enablements or funding, because certainly they struggle with that because of the nature of the populations they try to serve, and also because of geography always becomes difficult for them. And so any ways we can help them certainly would be helpful.
Yeah, yeah. Well, I'm glad we had a chance to spend some time with Dr. Place, and I know this is an area that A&M continues to be interested in, and hopefully we can be part of that solution.
I agree. Very important.
Great. Thanks. Enjoyed doing this with you, Aaron.
Yes, thank you, David. I appreciate it.
Take care.